Screen time, the environment, pollution, so many things are coming at us all day, every day that can trigger ocular surface disease. What's an optometrist to do? I'm Dr. Damon Dierker. I'm Director of Optometric Services at Eye Surgeons of Indiana. We're going to delve into modern ways to approach ocular surface disease management, including using nasal neurostimulation as a way to manage patients that come into our practices that present with a variety of presentations of ocular surface disease. And if you're not going to be the one to do that, how do you find somebody and collaborate with that person, whether it's to provide that next level of care for your patients to incorporate this new technology? So when I think about how we define ocular surface disease, I look back at DEWS 2. And this is going to be a patient that is symptomatic, that has some sort of loss of homeostasis. And how we find that in the clinic, we either look at their tear osmolarity, or we look at ocular surface staining, or we look for a reduced tear breakup time. We all have a broad term that we will use as ocular surface disease. And under that umbrella, we have dry eye, we have meibomian gland dysfunction, we have blepharitis, we have other things like conjunctival chalasis that can present with dry eye symptoms. So all of these things we need to have a really good understanding of not only the diagnosis, but then our treatment modalities that are going to work best for our patients. When we look at identifying symptoms of dry eye in our patients, of course patients can have dryness, grittiness, burning sensation, but I think really dry eye is a visual disorder. So patients that have blurry vision, fluctuating vision, vision that's worse later in the day, eye fatigue, all of those things we really need to think about. It's not only how they feel, but it's how they see. So when I think about how ocular surface disease and dry eye specifically is impacting patients, it is significant. Even I'm in a referral center practice and I see patients that have very advanced disease. I've had patients that have tried to commit suicide because their dry eye was so significant. Taking a step back, what's more common? I can't get through my workday. I can't wear my contact lenses. I can't do the hobbies that I enjoy. I can't go and watch my kids' basketball game without having to put drops in and do other things to get through my normal day. So dry eye is going to be something that has a significant impact on patient quality of life. That's why we need to take it seriously as optometrists. So why do we get dry eye? It used to be perimenopausal females. That's what we thought a couple decades ago. Dry eye is getting younger and more gender neutral. Well, why is that? Contact lens wear, screen time, we're not blinking enough, exercise, diet, environment, many things are coming at us. That's why we are seeing patients with dry eye disease that are younger, starting to see more males. Still female is the predominant, but I think there's a lot more risk factors for dry eye in our modern world. Certainly there's a role for lubricant drops or artificial tears. There's a trend now towards preservative-free, multi-dose, so I do think there's better options for patients that are out there. In addition, in my practice, I'm an advocate for nutritional supplementation as a foundational part of our treatment strategy. And then looking at patients with lid margin disease, MGD is so common and is contributing, we really need to address that. I do think there's still need for a microwavable warm compress, lid scrubs, other things that are OTC for a patient. So I think we look at that level 1 therapy, we shouldn't forget about those things because those things can help a lot of our patients. As we look at patients and they need beyond level 1 therapy, and that's the most common thing that I'll see in my practice, patients that have self-medicated or maybe they've seen another eye care provider and done something but still are struggling with their disease. I'd really look at that level 2 treatment. Level 2 treatment is going to be prescription medication and or in-office treatment for lid margin disease in particular. When we look at the available options for topical therapy, we have immunomodulators with cyclosporin and lifitegrast, which have been around for years that are very impactful for patients. You need to find patients that have loss of homeostasis, patients that have ocular surface staining, tear osmolarity that's increased. Those are patients that I'm going to want to incorporate a therapeutic. When we look at other ways to manage patients topically, topical steroids, loteprednol in particular, on label for dry eye flares. So it's very common for me to identify patients that are either in a flare or they have a history of having dry eye flares, and I'll use loteprednol then as a more or less rescue inhaler for that patient, is the analogy that I use, so they can have that to get relief when they have these breakthrough symptoms. I think that we are continuing to evolve now. We have a medication that's an anti-evaporative that we can use for patients that have MGD and evaporative dry eye. And this is really a nice place to start when patients that come into your office, they really need RX therapy based on the fact they failed tears or they're having symptoms they can't manage with their current techniques. Perfluorohexyloctane is an easy add for that patient, very well tolerated, signs and symptom improvement. I think this landscape continues to grow. We're going to have some things coming along in the near future that are exciting as well. In addition to topical therapy and RX treatment, we do have in-office treatment for patients, whether that's light-based treatment, IPL, low-level light therapy, thermal-based treatment, variety of technologies there. And many times our patients need both things. You really have to identify all of the things that are contributing to their dry eye and really develop a patient-specific, customized treatment plan for patients, not one size fits all. But there's still some gaps, for sure. There are patients that can't take eye drops, the drops burn and sting, maybe there's some access issues. Maybe you've tried these other therapies and they just haven't had much success. So one of the techniques to be able to fill these gaps is actually neurostimulation. And we've had that now in eye care for several years. It first started out as an intranasal device that's no longer on the market, but we know that if we are stimulating the trigeminal nerve in our nasal passage, that will actually trigger a basal tear production. All of the different components of a tear, we can utilize a basically on-off switch inside our nose via the anterior ethmoid nerve to be able to produce natural tears. So you can do that via device or you can do that pharmacologically. Internal device is no longer available. There is an external stimulating device that patients would use that has had some play in the market. It's not widespread. I've had a few patients on that. I do think that there is some potential for that to continue to grow. But in my practice, really, I've moved towards pharmacological treatment with neurostimulation via a nasal spray. So varenicline nasal spray in particular is indicated for signs and symptoms of dry eye. And what that is doing is a twice-a-day nasal spray that is going to trigger natural tear production. And what's nice about that, when we look at the trials to get that approved, they actually looked at patients that had mild, moderate, and severe disease. And it was shown that patients, even the first time that they use that, have an increase in their Schirmer's test. And then majority of those patients started to have symptomatic improvement after several weeks. So for me, yes, devices out there, and maybe there's going to be another device that comes in the future, but intranasal neurostimulation via a nasal spray is my go-to now. And that can be used in a variety of ways. That can be used in someone that has failed artificial tears or immunomodulators, and a next step for a patient. Certainly a patient, when you put fluorescein in the eye and they have a low tear meniscus, or you look at their history and they have things that would contribute to poor tear production. They have autoimmune disease, they have diabetes, they're on lots of systemic medication. Well, if we have something that can improve basal tear production that works quickly and it works in the majority of patients, this is something that's been a welcome addition to my practice. So we've looked at nasal neurostimulation as a possible way to treat patients with dry eye disease. What's the low-hanging fruit here? The patients that aren't making enough tears, Sjogren's patients, RA patients. But I think, yes, that is a patient that you can hit a home run with. But think about your patient with contact lenses. They don't want to have to take their contact lenses out to put in their dry eye medication. Or maybe they just have tolerability issues, burning and stinging that we'll see with some of these prescription medications. I think females don't really want to mess up their makeup when they put eye drops in. So patients, we don't always have to run to eye drops. I use eye drops a lot, but I think there are patients that really are better served in treating their dry eye in a different way. And intranasal neurostimulation has been really a success in my practice. So for some patients, when we use nasal stimulation or neurostimulation, it can be a primary treatment where really that's our core focus. Or sometimes I'm doing things in the office to treat their lid margin disease, treat their meibomian gland obstruction, that really just need to continue to have something to ramp up that lacrimal functional unit. So for some patients, it is the primary therapy. For others, it's adjunctive therapy. And I make sure that we identify how we're using this sort of technology for our patients to set them up for success. A 49-year-old white female referred to me for an ocular surface disease evaluation. We do give patients a speed questionnaire, and this patient had a 14 out of 28 on their speed, so they have moderate to severe dry eye symptoms. Their tear osmolarity was slightly abnormal, 302, 292, and when we tested their MMP9, it was found to be elevated in both eyes. The patient had a history that had been diagnosed with dry eye, meibomian gland dysfunction, as well as rosacea, but they just were not getting a whole lot of symptomatic relief. Continuing to have burning, fluctuating vision, had been on cyclosporin before, but really not very compliant, having some trouble with administration and tolerability. Visual acuity was 20/25 in both eyes. When I walked in the room, clearly this patient had facial rosacea. I could even see lid margin erythema. So my plan was to add an omega fatty acid supplement, do some in-office lid margin exfoliation, and then have the patient have a IPL course to attack that inflammatory eyelid disease, more from a Crisco appearance to clear olive oil with IPL course. And then at some point, I'm going to do some thermal expression. That continues to evolve. Intranasal neurostimulation, I think you could consider at any point in this treatment course because this patient is not making enough healthy tears. We now have perfluorohexyloctane, which should be reasonable. And I think in my case, it's probably a combination of things. So doing some additional in-office treatment. I would do 1 or 2 more sessions of light therapy, probably another thermal expression to see what I can do. But I'm also going to consider the topical immunomodulator, probably considering something like intranasal neurostimulator for this patient as well, since they're really not wanting to do eye drops if she can avoid it. I think it's a combination now, next step approach. And really to be determined how this patient does. This patient I've seen recently, and I think it's looking at all of the tools that we have, trying to identify how they got here, what are our treatment goals, and then really having a personalized, customized plan for that patient. So we know dry eye disease is nearly ubiquitous. We've talked about it skewing younger, more risk factors, modern lifestyle, et cetera. I think everybody needs to be a dry eye doctor to some extent, and that may just be simply screening a patient and referring that patient to a colleague that can manage that. I think you can look at level 1 and level 2 therapies and say, hey, I'm going to do these things. I'm going to recommend nutritional supplements, lubricant drops. I feel comfortable with the RX treatment, but maybe I'm not comfortable in the device space, or I'm not comfortable in these patients that have recalcitrant disease. It's okay to refer those patients. And then you've got someone like myself, it's like, I'm all in for dry eye, and I love doing this stuff. I love working with the complex patients. And I think that you don't have to do all the things that I'm doing in my practice to be successful. I think you look at what makes the most sense for your patients and your practice, start somewhere, then I think you'll find that you can do so many things to improve a patient's quality of life that your interest will probably continue to grow, and then you just layer on the things that you can offer that patient.